We have been, as physicians, scientists, and cardiologists, has been thinking about what is this? I mean, last maybe 1.5 decades, we are listening to this harping of so-called inflammation. We gave antibiotics during acute myocardial infarction a decade back, and we gave antibiotics to, but then that failed. I mean, that did not really catch up the momentum. So what's really happening? We really, unless somebody puts millions of rupees to really investigate and go into the depths of, because otherwise we'll be losing a huge important aspect of the disease, which we'll otherwise have to carry on what the Western world tells us. Like one of the Indian pharma found out a molecule in anti-diabetes, you know that. Like, why can't Cadila bring up their own innovative ideas to make life simpler for Indian patients? With that, I would also tell you that recently we had an array of patients with myocardial infarction, acute coronary syndrome, with acute malaria. What I mean is the patient came with fever. I don't know whether it happened in Goa, I'm not sure, about a year back, 2 years back. A lot of malarial falciparum positive patients suddenly getting myocardial infarction the second day, third day. There has to be some inflammation, because we couldn't prove it because we did not have any, but so many number of patients of malaria had myocardial infarction cannot be just a conjuncture thing. It has to have a causal relations, which a lot of people are researching now. So that's one part of it wherein we thought that there is some kind of inflammation, infection maybe, but at least inflammation. With that, when we go on to the cardiovascular epidemiology, as our dean, Dr. Nayak, told very clearly what are the standard risk factors. Well, today I would not start with hypertension or smoking, which is coming down, but the diabetes is going to be a burning issue. As he rightly told, India is becoming the world capital of diabetes by 2020. Already we are the world capital of tuberculosis and HIV. And to the dubious distinction, we will be the world capital of coronary disease and cardiovascular disease if we do not take the right step now onwards. What I mean to say is that already globally 31% of the mortality occurs with CVD. India, of course, this maybe this ratios are underrepresented. 28 to 30% already occurring because CVD, cardiovascular, means either a myocardial MI or a stroke. And most annoying thing, in fact, one of the big studies were done in JJ Hospital about 10 years, 15, 20 years back, wherein we've just found out how many patients who are coming with myocardial infarction, acute coronary syndrome were less than 40 years. It was staggeringly 16%, which is very, very uncommon in European and American standards, which is just 4% or 3%, which is 16%, is a very, very high nature. Something has to be there in India, which is not the real picture being represented in our. We all know diabetes is itself a coronary risk factor. The diabetics have 4 times more the risk of getting a myocardial infarction. And lipids, we have been hearing about that, the raised LDL, reduced LDL. Nowadays, the triglycerides are also going to be important because the subset of abdominal obesity, high triglyceride, and high dense LDL and low HDL is going to be important in Indian patients. We'll see that. Of course, we're not the gamut of the talk here. Hypertension has been a big problem because it is a silent disease. It's called a silent killer because people can have hypertension for 10 years but do not have any symptom for that. Of course, other things like hemostatic, the thrombotic, behavioral, well, you all know, the smoking, the drinking, other things, and demographic, where you live in, and the genetic. Looking at all of these things, after having solved all of this, do you still have unanswered things? Yes. If you look at the ratio of the coronary disease, the risk factors, you'll see that about 71 to 72% patients will have, or even 80% will have some risk factor. But 19 to 20% of patients do not have a risk factor. What do you mean by that? Why should we suffer from a heart attack without any risk factor for that? Your daily walks, he's not a smoker, he's not a boozer, he doesn't smoke, he doesn't have hypertension, diabetes, lipids, still he had MI. This is, I don't know, I'm sorry to tell that, we found more common in Jain community in Mumbai, wherein a lot of Jain patients, even though pure vegetarian peoples, had high triple cell disease when we had an angiography done very commonly. So there has to be something which we don't know. I still don't know, but we're trying to tell you what else can we look into that. The 60% of the patients who have one or two risk factors, and 80% will have something, whereas about 20% I told you wouldn't have a single risk factor. So there is something like inflammation or something else we are looking at it. When you look at this chart, when LDL was fixed at 100 or 80 or whatever levels, when you compare this high sensitivity CRP, the marker which you can assay, which can measure, looked at less than 1 to 3 or more than 3. More than 3 was thought to be a high risk factor for a high risk subset. When you see that there was a logistically high incidence of cardiovascular disease when the patient had the same LDL for the given different 3 levels of HSRP, which is an important marker for the inflammatory biomarker for the CAD. So having said that, the American Heart Association said that we could measure the HSRP for all of the patients, but entire population should not be screened. It's not correct. In 2010, we said apparently we can do in elderly people at least to know above 50, 60 years. And now at least we use of this HSCRP for stratifying the high-risk patients. What if a high-risk patient has 2 risk factors, hypertension, diabetes, family history diabetes, family history hypertension, and family history with a stroke or a MI. These patients should definitely, as you have a lot of laboratories giving you the values for HSCRP is very important, as well as serum homocysteine, which both be a newer risk factor to the standard risk factor for coronary disease. So what as a scientist we should try to look into the basic pathology wherein how the atherosclerosis builds up. This beautiful slide will tell us that the monocytes, because of the endothelial damage, because of stress, hypertension, smoking, LDL, gets the monocytes inside to the cell, and the LDL also gets into the cell wherein it's oxidized. The oxidized LDL again gets attracted into the macrophage, causing a foam cell, so-called foam cell. But this, we knew it long back. What we did not know that the cellular mechanism to propagate this, the nuclear factor Kb or the PAPR gamma, which gets stimulated in the cell with the 2 pathways. One, to the NF-Kb pathway, or the other, the dendritic pathway, which is called as kynurenine pathway. These 2 pathways, which I think Cadell has put a lot of energy and resources to go into the details of that, to find out that when the stimulation of the NF-Kb pathway stimulates the inflammatory mediators like the interleukin, the TNF, the tumor necrosis factor, and by that we will have the release of the adhesion molecules. So the VCAM and the ICAM, the adhesion molecules get more monocytes, macrophages to adhere to endothelium, form foam cells, aggregate the platelets, then the atherosclerosis becomes more malignant. This is a vicious cycle. So how to break this vicious cycle, we are trying to look at whether what we can do at a cellular level to cut off this so-called inflammatory mediated pathway. The other pathway wherein the oxidized LDL will get into the foam cell or the dendritic cell too is a kynurenine pathway wherein as a metabolite, the 3-hydroxy anthralic acid is a defense mechanism against the inflammation. So the balance of the nuclear factor KF factor as well as the 3-HAA, whether we can really control the inflammation at a cellular level by any other drug, we are looking at it now. If you see that the NF-Kb pathway has a self-propagating inflammatory mediators, endothelial damage, atherosclerosis, whereas kynurenine pathway trying to maintain that. So we have drugs like antiplatelets, PAPR agonists, but they are all used as secondary measures. Can we do something to halt this NF-Kb pathway? Can we stop the stimulation of that? Or can we increase the 3-HAA by the tryptophan metabolism? We are looking at that. So a drug called curcumin, wherein Dr. Nayak also will tell in orthopedics, I'm sure he will elaborate on that. Dr. Kamath will elaborate that. Wherein what it's doing in cardiology. In cardiology, the NF-kB inhibitor, so-called, it's a herbal medicine, still not come into the market, as he rightly said. I don't know, I was asking same thing in Bombay, but they are telling another few months because until they have got all the regulatory things, Kaushik, am I right? So, unless we have all the regulatory things, this is going to be another giant pharma getting one more molecule, like we had a lipaglyn molecule from one pharma for anti-diabetic and anti-triglyceride. It is so wonderful drug that no other drug has reduced triglyceride to that level in whole world by just a 4 mg of tablet, which has had a recent approval from ADA. But like that, I'm looking within 6 months, 1 year, 2 years, whether you can get an FDA approval, because the FDA is very stringent. Like us, we have to be stringent. So this NF-kB inhibitor can inhibit this pathway. By inhibiting, what it can do, you see that the inflammatory stimuli is through the kinase enzyme, which stimulates the NF-kB, which becomes active, gets the translocate into the nucleus, and by that into the nucleus starts sending messages to release of inflammatory mediators like the tumor necrosis factor, IL-6 and 1B and HSCRP. These all inflammatory markers will make the adhesion, release of course adhesion molecules and cause the cellular damage and atherosclerosis and inflammation of course at the ground root. That's what we are trying to tell you. So this curcumin has multiple sites of action. What are they? It can prevent the activation of NF-kB. It can prevent the translocation of it into the nucleus. It can also prevent the release of inflammatory mediators at one or all the 3 stages. By that, but at least the Cardiolab have done the research to tell that this is an innocuous molecule with barely no side effects, can give decrease of C-reactive protein and decrease of what they had in study, when they used it, the molecule has decreased the MI, also the CABG, significantly reduced the serum cholesterol, and also increased HDL, and also prevents the progression of diabetic nephropathy, and attenuating proteinuria, decreasing fasting sugars and HbA1c. All are very beautiful indirect ways of telling that this molecule is doing something, which added to all the molecules can be a real phenomenal drug if it really holds on to what it has been telling. The other pathway, how to prevent the NF-kB release or this thing is by through the kynurenine, as I told you. If you can stimulate this 3-hydroxyanthralic acid, 3-HHA, the anti-atherosclerotic effect of this beautiful molecule is by reduction of LDL, increase of HDL, and this 3-HAA is an intermediate metabolite of tryptophan. Tryptophan, when metabolized through this kynurenine pathway, it can activate it can inhibit the nuclear factor Kb and also induce the nitric oxide synthase of INOS system, wherein the good interleukins like IL-7 and 15 can be stimulated, vasodilatation can occur, and inhibit the nuclear factor so that cellular adhesion and atherosclerosis can be reduced. This is all I've been hearing, a lot of things from them, that it can reduce the cholesterol, reduce the triglyceride, and also increase to HDL to some extent. It can be really, really very, very promising to hear this molecule really works like that. And we are looking forward for this molecule, which has got such a huge cellular level action by inhibiting the atherosclerosis at a ground root level. So, and also it can have effect on the atherosclerosis by significantly reduce the inflammation, and also it can to an extent reduction in the atherosclerotic lesions can occur, shown in this microscopy or the electron microscope cameras. In summary, 3-HHA is intermediate metabolite of this kind of pathway, that is a tryptophan metabolism. It has many significant effects like reduction of LDL, triglyceride, and increasing HDL to some extent, and also reduce vascular inflammation is very important, because we don't know what is causing all the myocardial infarctions in the world. We are trying to believe all the so-called standard risk factors. Something else is burning, which we need to look at it, because India has got so many diabetics, so many maybe smokers and hypertensives. We need to look at the inflammatory markers and reduce them by this great drug, which we are looking at it. Many other studies which are coming in the pipeline, like those with phospholipase inhibitors or suppression of leukotrienes, I am sure the curcumin will come ahead, and despite this optimum therapy with current drugs, still 1/3 of the low-risk individuals have been known to develop the atherosclerotic heart disease. Controlling inflammation will really improve the cardiovascular outcomes and may also further help reduce morbidity and mortality, which is going to be very important because 80% of the diabetics, 80% of the nephrology patients, and all of the diabetic and hypertensives have a terminal death due to cardiovascular mortality or a stroke or a renal failure. So this has to go to very, very important by reducing the inflammatory pathway. Thank you so much.